So Dr. Amit Raj, who is heading the Department of Ophthalmology in AIMS Patna, and also has a lot of presentations everywhere, and the various papers published in various journals, would be speaking on this important topic, that is cataract surgery in post-intravitreal injection cataract, which is again a little different than the usual cataract management. So, Dr. Amit.
Thank you, sir. First of all, at the outset, I am thankful to Subhash sir for making me part of this IC. And coming to my topic, phaco in post-intravitreal injection cataract. As you know, intravitreal injection, especially anti-VEGF, is one of the part and parcel of not only retinal although also general ophthalmologist also give so many injections. So in US it has surpassed the number of cataract surgery, and there are a lot of indication like ARMD, neovascular, diabetic maculopathy, CRVO, etc. And a cumulative incidence is around 0.44 to 0.6%. There is an array of complications right from subcontractile hemorrhage to raised IOP, retinal complications like vitreous hemorrhage, RD, endophthalmitis, cataract, and even CRO has been reported. This is one of the landmark study in which author has investigated the risk of PCR after cataract surgery in post intravitreal injection. Out of the total around 63,000 cataract surgery, there was a history of previous injection in 1.64% cases, and PCR occurred in 1.04% of cases. And after logistic regression, it was found that there was increased risk of PCR in cases where there was previous injection of intravitreal injection. Again, another study that has been published in Current Eye Research, and in this study again author have concluded that the result was out of total 10,327 cataract surgery, 308 has history of anti-VEGF injection, and out of 308 eyes there was 8 around 2.6% as PCR, while in rest of the eye only 45 eyes has PCR, that was 0.5%. Most recent study that has been published recently in ACTA Ophthalmol. In this basically it was a systematic review and meta-analysis, and out of this basically around 10 lakh eyes has been included, and again in this study it concluded that there was a 4% higher risk per injection. So what is the mechanism of cataract after injection? There may be faulty technique, it may be site, it may be needle, longer needle, uncooperative patient may have moved eyes, patient may have moved head, there may be direct inadvertent zonular trauma, or due to deforming of the globe damage can occur, there may be direct PC contact, and there may be different rate of cataract formation after anti-VEGF or after intravitreal triamcinolone or dexamethasone. Highest is with intravitreal triamcinolone. So what precaution one should take while giving intravitreal injection? First, one should know the phakic status, whether patient is phakic, pseudophakic or aphakic. Preferred site of injection is again important. Most preferred site is superior temporal, inferior temporal, and then superior nasal. And again, you can say thinner gauge of needles should use. And what are the clinical cues? Clinical cues is a needle track penetrating the lens, loss of convexity of the lens. And one should always take help of different modality, UBM, B-scan, intersegment OCT, sample imaging. Again, one study in which it has been found that most specific and sensitive is UBM, compared to sample imaging and B scan, intersegment OCT, sorry. So what are the key issue is in management? There is always risk of nuclear trap. You are not knowing whether needle track injury is there. Sometimes there may be mature cataract. There may be VR setup, or you can say VR assistance, and one should perform these cases in perivalvular anesthesia, and patients should be counseled maybe for longer inflammation, longer surgery, or even second surgery. So one should all treat these cases as posterior polar. So in this case, it was deemed as posterior polar. So all the precautions were taken. One should avoid hydrodissection. Hydrodelineation should be done. Bottle height should be on lower side, and one should use bimanual technique for aspiration of cortex. And viscodispersic agent should be used to tamponade if there is PCR, and there should always be a standby 3-piece lens or even PMMA if it is not available. So fortunately there was no PC defect, but you can see the pigmentation in the posterior polar area. Second case, second case, this case has been done by Suhas sir. Again, hydrodissection has been avoided. So at this stage there was PCR. So one should not rush out the basically instrument. First, one should avoid sudden decompression. First, viscoelastic should be injected. And sir has gone through pars plana route. Basically, trocar has been used. And in different study, it was found that vitreous clearing is better when you are going through pars plana route.